Bismillah ar-Rahman ar-Rahim. Good morning. We are going to start this second day with an important session. I am Dr. Shah Yusuf, working as Assistant Professor and Head Department of Gastroenterology at Peshawar Medical College and Prime Teaching Hospital. I welcome you all at this very important session, especially important for young people who are in the start of their career and those who are at the end of their training. This is ERCP, which is very important, and we are having very eminent speaker in this to learn the tips and tricks of ERCP from these experienced speaker. We have session 5, which is predominantly associated with how to do ERCP cases. So we are starting this session by inviting chairs of the session. So I will request Dr. Zabiullah to come on the chair. I will request Professor Altaf Alam Saab to join us as a chair. I will request Professor Wasimuddin to join us as a chair. I will request Professor Arif Nadeem. Okay. And we have Professor Ghayasun Nabi. He is not available at the moment. So our first talk will be a very eminent speaker who is basically integral part of this PSG, and he is very supportive from UK. He is always available to support PSG, and we are having Professor Waqar Ahmed, who is working as clinical lead HBP medicine at Northern Clinical Alliance, Manchester. I will request Professor Waqar Ahmed Saab to come and tell us about ERCP training tips and tricks. Thank you.
Assalamu alaikum. Thank you very much for your kind introduction. And also I would like to express my gratitude to PSG and Professor Sher Rahman, President PSG, and Professor Kamran Hassan for kindly inviting me to this meeting. It's always a pleasure to come home. This is, in fact, I mentioned it in the inaugural session as well. This completes my 20th year of participation in PSG meetings. My first time I came to PSG was in Peshawar as well in 2005. So it's been a very happy journey with you all. Now my topic is ERCP training tips from an expert. I'm not so sure about the second bit of the topic. Right now, ERCP, as you all know, is a very highly skilled procedure requiring an exceptional degree of procedural and technical skills with a high risk of complications. So it is something which has to be treated with great respect. You know, there's been a tremendous technological development in endoscopic equipment, the hardware, the software, the accessories, and there has been a significant reduction in the complications of those procedures. However, in ERCP, for some reason, the risk of complication over the last 35 to 40 years has remained static. So it is a procedure which has got a definite, though low risk of complications, but it's something which has to be taken into account and treated with respect. Now again, ERCP is not a type of procedure that you watch a video and you start doing it yourself. It's not a DIY or a teach-yourself procedure. It's not that once you have attended this lecture or a workshop, you can start doing it at home. You know, as you can see, sometimes you see these videos of circuses or watch a circus and they tell you, do not try this at home. So ERCP is not a procedure that you try at home. So you have to go through a proper training program. In the past, the training has been rather chaotic and random. Normally, ERCP training should be part of a dedicated program. It should cover it in a more holistic manner. And first of all, before anyone embarks on ERCP training, the trainee should have already achieved competence in upper GI endoscopic procedures. They should have completed all the key, they achieved all the key uh, performance indicators and should be deemed as competent in those, because you can only run after you start to walk. Now, the components of training, there are various components of training that are integrated into the whole program. And in an ideal world, it should start with simulator training, because there is less chance of doing harm. Obviously, you might burn a simulator, but that's all. We do not want you to cause any harm to the patient. So it should start with a simulator training. The candidates should be encouraged to attend dedicated ERCP courses. In UK, we call them mandatory courses, and it should be part of a training program in a high volume centers. So training is not just attending courses, it is working in a center where ERCP is practiced on a regular basis and lots of procedures are done. And again, it is also, the onus is on the candidate as well to do a self-directed study and try to learn various aspects of the procedures. Again, simulator-based training should be a structured training. There is a need for supervised simulator training. That's the way we do it in these courses and workshops. And the aim should be to make sure that the candidate is competent in handling scope and able to do the basic procedural skills on a simulator before setting them free on the general population. In simulator training, it should be a stepwise approach, starting with virtual reality type simulators and then going on to the manual one, which we do have available in various centers. Now, in all training centers where there is high volume training going on, their candidates should be encouraged to attend specialist mandatory courses in ERCP. These should have clear learning objectives. They should have expert faculties who are experienced in the procedure, and they're also skilled trainers and teachers. We have an excellent example of such a course in Karachi, which is at the moment the only hands-on training course in the country. And in fact, it's one of the few centers in the world offering such training courses, because in ERCP, in UK also, there's only one. Well, in fact, there used to be two centers, Stoke and Liverpool. I used to be faculty at Liverpool, but Liverpool has stopped doing their courses. It's only Stoke. So Karachi is one of the very few centers in the world to offer such courses. And we use exactly the same syllabus. Mandatory courses are very concentrated, dedicated courses. The way we run it, it has its own theory sessions. It's filled with lectures, mini tutorials. There are facilitated group discussions, we call them mini teaching sessions. There should be live demonstrations by the expert faculty, but the stress is placed on encouraging the candidates to do hands-on procedure under the guidance of an expert trainer. During these courses, we start off with, initially, there is a bit of a theory session, but in our own courses, we've cut down the length of the theory sessions to make it more interactive and more interesting. But we do start off with simulator training first before we set them free on patients. One of the requirements for these courses is that all the candidates attending these courses should not be totally naive to the procedure. They should have already done a certain a minimum level of about 50 or so procedures in their own home departments. Generally speaking, all these candidates should be encouraged to engage in self-directed learning. They should develop a knowledge base. They should read up about the different guidelines, the protocols of various specialist societies where they are working, and they should increase their skills in recognizing normal from abnormal anatomy, and should be able to perform safe and effective ERCP techniques. The training resources that we use for these for learning are your general textbooks, but nowadays hardly anyone uses textbooks. Everything is available online. I don't know when was the last time I opened a textbook. Guidelines from specialist society are usually very helpful. E-learning modules are there. You can find them online. There are web-based videos. Some of them are good, some of them are very poor quality. And then national and international conferences, something very similar to what we are doing now, plus live endoscopy workshops, which we did 2 days ago. I think in the structured ERCP syllabus, the candidates should be encouraged not just to do the procedure, but also to learn about the indications, the contraindications of the procedure. Should be able to explain the risk versus benefits of the procedure, and should be able to take an informed consent from the patient. They should also be able to, because the ERCP is a procedure that you would require sedation for, and they should be able to explain to their patient the concept of conscious sedation, deep sedation, and general anesthesia, as well as guidance on prophylactic antibiotics. I think to be able to do any procedure, you need to know your tools. You should be familiar with your scope, with processors, with fluoroscopy equipment, and basic troubleshooting techniques. If your scope is not working, if something goes wrong, you should be able to fix it in a basic way. The best I can do normally is switch the equipment off and switch it on again and hope that it works. Most important, ERCP uses a lot of accessories, in the procedure. One should be familiar with your cannula, sphincterotome, guide wires, stents, balloon catheters, lithotripters, everything. And most important of all, something which we find here is that there should be no unnecessary personnel inside the room, because number one, it is a distraction. Secondly, they get in the way. And thirdly, it is dangerous for them because they get exposed to unnecessary radiation. Before we start on ERCP training, everyone should undergo a radiation safety course. Now, it is very important to know the etiquettes of the ERCP suite. The person conducting ERCP should show effective leadership in keeping and gelling his team together. They should have a patient-centered approach. There should be a constructive coordination amongst the various team members. There should be an understanding between the operator and the assistants. If I turn around, I normally get the accessory that I'm expecting. There should be such a way, a coordination between the operator and his assistants. There should be a good coordination between the radiographer. They should know when to get the shot, how to do the screening safely, where to mag it up, where to zoom out, and to minimize the exposure of all the attendees in the ERCP suite. Again, decontamination of your scopes is very important. In our center and in all setups, there should be regular pre-ERCP and post-ERCP MTTs. There should be team debrief after procedure, whether the debrief is done straight away after the procedure or it is part of the MDT afterwards. There should be monthly regular monthly mortality, morbidity meetings, clinical governance meeting, and not just in ERCP, but in all endoscopic procedure, we conduct WHO checklist. I'm sure most of my colleagues from UK, and I'm very sure in US as well, they have a similar sort of protocol. Whenever any patient comes for endoscopy in our units, they are first admitted by the nursing staff who take all the history, the patient's indication, for the procedure, any comorbidities, any medication they are on, any allergies. That is all done before they come to the ERCP suite or the endoscopy suite. Again, once they are consented and they are brought into the suite, before we touch them, we go through a WHO checklist. And you can see all the things that are recorded there. Their names are reconfirmed. Again, their allergies are checked, everything, whether they are on anticoagulant, antiplatelet agents, and when did they last take those medication. So everything is checked again. The only purpose of this is to minimize errors for the patient's safety. Sometimes the patient may get irritated. He said, well, I've given all these details outside. Why do you want to ask me again? But again, it is always for the best interest of your patient. The procedure, obviously, you need to learn how to handle your scope safely, especially with limited supplies. You don't want to break your scope every 2 or 3 weeks. Proceed safely through various steps. There are certain critical steps during the ERCP procedure. There is esophageal intubation, journey through the stomach, which is very important. A lot of the time, people are in a rush to get to the pylorus and they end up in the fundus. So whenever you clear the lower esophageal sphincter, the scope should be directed toward the right and downwards. At times when the patient has a J-shaped stomach or partial volvulus or a big paraesophageal hiatus hernia, you may get trapped inside the stomach, and you should know what various maneuvers to take to get out of it. So those are the sort of things you do. Duodenal intubation, again, is important. We always teach them to follow the setting sun concept of getting into the duodenum. And most important of all, I'm not going to delve on that because the next the next lecture is going to be on that, is position of the papilla. Selection of the right accessories for the right procedure. Most of the time, you know what you are going to do. You know that the patient has got a naive papilla, it's a virgin papilla. So if that's the case, you would ask your nurses to prepare the sphincterotome. You do not want to be started looking around for sphincterotome or balloon catheters when you are there. So it should all be ready. Guide wires of the right type are selected. Balloon catheters, everything should be all prepared in advance. The various type of stents that are available to you, you should be able to pick which ones. It is important post-procedure to write effective, comprehensive reports so that if there's any complication or anyone wants to see that come across that patient, they should be able to tell what you did during that procedure. Early recognition of complication is most important, and owning complication is most important. Do not hide anything under the carpet, because that is criminal. Nobody is going to blame you for having complications during your procedure. That is a well-recognized entity. We all know that you can get complications during these procedures, but trying to hide complications is criminal. And one should have easy access to other colleagues like hepatobiliary surgeons and interventional radiologists. Now, how much training does a candidate require before he starts or he's allowed to do independent practice? That is a very difficult question to answer because everyone is very individual in his aptitude for the learning procedures. There are so many variables. I've been training people for well over 20, 25 years, and I find people of different abilities. Some of them are very easy to train, some are a bit more challenging. So, but generally speaking, from statistics and from learning from other procedures like colonoscopy and other things, training period of at least 12 months in a high volume center is usually considered to be, is deemed to be sufficient. Minimum number of 300 ERCPs to achieve basic competency. In the past, it used to be 200, but we felt that 200 was inadequate. Once they have achieved that competence, a further 12 months period is required which we normally mentor, is the candidate or the trainee or the clinician is supervised by a senior clinician. Whenever they are in a high training center, in a high volume center, they should be actively involved in all CPD activities, MDT meetings, pre and post ERCP cases and imaging should be discussed on site, and easy access to HPB surgery should be available. They should be able to discuss their cases with oncologists in MDT, especially in cancer cases. Interventional radiology facilities should be available. And trainees should be encouraged to engage in research and service development activities. And there must be a robust clinical governance and audit system. The trainers, who should be the trainers? Trainers should have, well, they should be expert in the procedure, but they should also be good teachers. They should be able to train the candidates in a way that the candidates are happy to work with them and learn from them. The trainers themselves should be performing an adequate number of procedures, and their job is quite high risk and challenging. So they should have the maturity to take on the job. Now, what is considered as a difficult biliary cannulation? Where do you stop your trainee? More than 5 attempts with the papilla is something which we use as a standard thing. More than 5 minutes of having attempts at to cannulate the papilla is another criteria. And more than one unintended PD cannulation or opacification. A trainer and trainee should have very clear rules of engagement. When the trainer tells the trainee to stop, he should stop and take over. Because going beyond that or attempting beyond that would be unsafe for the patient. Your patient should be your center of attraction. Yeah. Formal assessment tool. During any decent training program, there should be formal assessment tools like DOPS, direct ops. We always use our DOPS. In US, they use the TSAT. I'm not very familiar with that, but I've looked at the documents, and they are very similar to DOPS. It should highlight the trainees' strengths and weaknesses. It should be used to improve performance. And at the end of the training, the trainee should go summative assessment, which is again through DOPS procedure, and it's considered as what we call summative DOPS. I'll quickly run through those. Summative assessment should be carried out, the final assessment of trainees should be carried out by 2 independent assessors who are not the trainees' regular trainers. And training steps in ERCP, the trainees should be trained up to SHIELD level 1 and 2 competence, which is selective cannulation, extraction of stones of greater than 10 millimeter, treatment of bile leaks. These are simple ERCPs. The ones who are required to do advanced procedures should be carried out by people with more advanced training, like stenting, a hilar obstruction, removal of intrahepatic stones, pancreatic therapy, ampulectomy. Those should be done by more experienced things. Key performance indicators to indicate a trainee's competence in basic ERCP. For the trainee, it should be greater than 80% cannulation, but when they go on to do independent practice, it should go to 90%. 80% is only for those who are just at the end of the training session. Complete stone clearance of greater than 85% after successive cannulation, and successful stenting of distal biliary stricture in greater than 90%. That should be the key performance indicator of anyone doing independent practice. Overall, post-ERCP pancreatitis should be less than 10%. Again, this is a basic repetition of what we said, and thank you for your kind attention. No question.
Thank you, Professor Waqar. Question will be taken at the end of the session. We have our WhatsApp number. You can send the question over there, or you can ask directly at the end of the session. So our next talk is a very important talk, which is about CBD granulation. It will be tips and tricks, and this session will be I will say a guru of ERCP and EUS, Professor Muhammad Khalid Hassan, who is working as Professor of Gastroenterology at Orlando, USA. He is advanced interventional endoscopist, also working as medical director and director of advanced endoscopy fellowship in education at Center of Interventional Endoscopy. We will be having his session online, and he will be available for question and answer session as well. So, Professor Khalid Hassan.
First of all, thank you for the kind invitation, and Assalamu alaikum. Thanks to Kamran, Sheikh Rahman, Arshad Janoon, the whole committee, the organizing committee, giving me opportunity to present at PSG. I'm sorry I'm not there physically, but I'm there spiritually and virtually. I am really missing the company of friends and colleagues. Hopefully, inshallah, next time I will be able to join. So my today's topic is biliary cannulation tips and tricks. It's a long topic. I'll do my best to give some tips and tricks in next 20 minutes. ERCP, before we go into the procedure itself, I always like to look at the historical perspective. First ERCP performed in 1968 by Dr. William McCune. Then my teacher, Dr. Peter Cotton, reported 6 cases of ERCP. First endoscopic sphincterotomy was performed in Japan and Germany simultaneously. Then comes the paroral cholecystoscopy, and then placement of prosthesis like a plastic stent. Then come the metal stents in late 80s. And since its inception, the role of ERCP really has parallel technology innovation. There was a dramatic increase in performance of ERCP from 1988 to 1996, and then steady decline in diagnostic ERCP. The reason for that was because of new technology like ERCP, EUS. They came as a diagnostic modalities. Then ERCP utility for diagnostic purpose decreased. Currently, basically, ERCP is mostly performed for therapeutic indications, stone stricture being the most, and then the others. Mostly therapeutic purpose, but it does have some diagnostic indications. So mostly ERCP now is for therapeutic purpose. Some diagnostic indications are cholangioscopy and pancreatoscopy and staging of cholangiocarcinoma, etc. But currently, because of availability of other diagnostic modalities, ERCP should be only therapeutic. Going through the normal pancreatic biliary anatomy, major papilla on the medial wall, drains bile duct, ventral pancreatic duct. Minor papilla, on the other hand, is 2 centimeter proximal to the major papilla and is on the bit lateral side. It drains dorsal pancreatic duct. Looking at the anatomy of the ampulla, if you look at it, obviously there is an orifice, and then many times, unless the papilla is flat, many times there is a covering hood, and there is a bulge, suprapapillary protrusion or bulge above the orifice. And then there is one other thing which called a ridge or longitudinal frenulum. That is just below the papilla. In this case, you can see in this picture right here, but this is another picture of a peripapillary diverticulum. And you don't see the papilla or the orifice itself, but if you use your sphincterotome to move the fold around, then you will be able to see the papilla right here under this fold. But what really helps you recognize is this ridge, which is where the folds are converging, and there is a longitudinal ridge. So that can give you sometimes an idea where the papilla is. Papilla, ampulla, they are used synonymously, but there's a small difference between those. Papilla is the intraduodenal part, which includes the mucosa, orifice that bulge into the duodenum. That's called the papilla. On the other hand, ampulla is in the wall. That is where the pancreatic duct and the bile duct, they connect together and make a common channel. So consider it like a ampulla is the plumbing in the wall, and papilla is the faucet. So some difference at times helpful because how much sphincterotomy you have to perform, biliary sphincterotomy or pancreatic sphincterotomy, or the length of the common channel itself. Pancreaticobiliary junction or common channel can usually is less than 5 millimeter, but can range from 1 millimeter, or actually I should say 0 millimeter to up to 14 millimeter. There may be sometimes two separate openings. When the common channel is longer than 8 millimeter or 10 millimeter, then we start thinking about abnormal pancreaticobiliary junction. So keep that in mind. If it's longer than that, patient has a recurrent pancreatitis. The reason for that could be an abnormal pancreaticobiliary junction. Normal pancreatic anatomy, normal common bile duct diameter usually is less than 6 millimeter. There could be a functional dilation like in post-cholecystectomy patients or narcotic use. Anatomical variations do exist, but usually in post-cholecystectomy cases, the diameter of the bile duct should not be more than 2 millimeter than its baseline. Like let's suppose if it was 4 millimeter, it should be 6 millimeter. If it goes beyond that, then start thinking about there could be other issues, especially if patient is asymptomatic. How to improve cannulation rate? You should become a papillologist. You have to study the papilla. You have to talk to the papilla, and it is never banging on the papilla or pushing on the papilla. It's always slow, calculated movements at the ampulla that is going to increase the chances of selective cannulation. And there's a different technique for every papilla. Every papilla behaves differently, and you have to treat it as such. Let me tell you the 4 secrets of successful cannulation. Secret number 1, position. Secret number 2, take your time to get into a better position. And secret number 3, take extra time to get into even a better position before you touch the papilla. And then comes the movements. And the movements, you have to unlearn colonoscopy. You really need to have very slow, calculated movements and to get a successful cannulation. And traditional teaching usually is as soon as you get to the second part of the duodenum, lock your wheel. You should not lock your wheel if possible. It is always taking off the wheels, which is going to help you in cannulation and have very calculated movements. Usually we prefer short scope position where you can see the scope rest along the lesser curvature of the stomach, or long scope position where you can see the scope rest on the greater curvature of the stomach. And there are other situations, especially in cases of minor papilla. Usually it's a semi-long or long position that's going to help, but majority of the time we prefer a short position. You should not be having to hold the scope with both hands during cannulation. Only left hand should be controlling the scope with the help from the shoulders and wrist, and right hand merely supports the scope by pushing in or pulling out the scope, and it is used for accessories, for wire injection. So most of those your movements of the scope are going to be with the left hand, shoulder, wrist. Once you are in the second part of the duodenum, if you are worried about falling back, rotate the scope clockwise so your the scope are facing toward your chest, then turn yourself to the right in a way that the scope is hugging around the duodenum, and that helps you stabilize the scope and not fall back. If you unlock the wheel, you fall back, it's okay. Go back in there and reattempt at cannulation. Once you have cannulated and you're still worried about falling back, then you can unlock the wheels. But usually it is unlocking the wheels be able to move freely. That is going to help you really be able to get a successful. For is you can use buscopan, you can use glucagon, whatever is available to you, and to take a look at the papilla, move the folds around with the sphincterotome or cannula or whatever you are using to really have a good view and access of the papilla before you really start attempting at cannulation. Before we go cannulate the papilla, I want to show how to pass the scope. Duodenoscope is a side view scope. Side view means you're looking at the ceiling and moving forward. Regular endoscope, colonoscope, camera is in the front, you're looking forward, moving forward. Duodenoscope, looking at the ceiling, moving forward. EUS scope, camera is at 45 angle, like where the wall and the ceiling meet. That's where your camera is, and that's just keeping that in mind. Camera in duodenoscope and both EUS scope is behind backwards as compared to the tips of the scope. So in EUS, it's close to 1.5 to 2 centimeter. Your transducer is beyond the camera. In case of ERCP, similarly, the end of tip of the scope is beyond the camera. So if you don't think like where you're looking at, that's where the end of the scope is. Scope is a little bit beyond that. So once you get into the right below the GE junction, inflate the stomach. Stop there, inflate the stomach. You are trying to follow here the folds of the stomach. Now you're looking side view. Those folds are on the side. That's what you are looking at. Your scope is moving forward. If you go into the stomach and move the big wheel towards you, you're going to retroflex. So you have to just follow the folds gently with the scope itself. Once you get to the antrum or to the orifice, stop there, take your time. Once you get into the pylorus, again stop, follow the folds of the duodenum or the medial wall really to get to the papilla and advance the scope. So it should not be those useless movements to the right once you get to through the pylorus into the duodenal bulb. Stop there, gently move the scope. Here you can see once we get to the papilla, then shorten the scope, and that gives you a nice access to the major papilla. Axioms of cannulation: if the bile is flowing through the papillas, you should be able to cannulate the orifice, and it's always about exercise and being gentle with the papilla. Once you get to the papilla, take your time, have a nice talk with the papilla, and use sphincterotome to lift the folds, as I mentioned. Use glucagon or buscopan if there's too much motility. Short, long, whatever position that is, you should have a good access to the papilla and good control of the accessories or wire or tome or cannula to be able to negotiate the orifice. And other thing, remember that the bile duct runs parallel to the duodenal wall. Here, this is the wall, bile duct runs parallel. On the other hand, the pancreatic duct, at least for the first half centimeter or 1 centimeter, is perpendicular. So for biliary cannulation, you have to get underneath the papilla. For the pancreatic cannulation, small wheel towards you, orifice facing right at you, and go straight in there. So that is perpendicular to the wall. On the other hand, bile duct, get under the papilla. Big wheel sometimes away from you helps you better to get underneath, or gently advancing the scope, and that straightens the papilla or lays the papilla flat for you to be able to get parallel to the wall of the duodenum or bile duct to get into the bile duct. And usual tradition teaching other is biliary orifice is between 11 and 1 o'clock, and pancreatic orifice is between 1 and 2 o'clock. The way I do is, when I get to the papilla, you can see papilla is on the here, right in the upper part. I draw imaginary line, two lines, the vertical and horizontal, and this left upper quadrant is the biliary axis, and the right upper quadrant is the pancreatic axis. One other thing you got to take a look at is, unless it's a flat papilla, there's going to be bulge here. You do a little bit tap on suction, that bulge appears. And when that bulge appears, see where it meets the duodenal wall. And then have this imaginary line from the orifice itself to the middle of that concave part where the papilla meets the duodenal wall. That line is going to be your biliary cannulation axis. Maintain that with the wire or with the tome or cannula to achieve a biliary cannulation. I'll show you that in a little bit. With regard to wire contrast, who pushes it? It could be your assistant, could be yourself, physician assisted cannulation, or physician controlled cannulation, I should say. And one thing is, be able to spin the wire, be able to rotate the wire, especially to get to the through the difficult angles. You can use the tome, cannula, whatever works for you. There are different sequences of options for cannulation, wire guided or injection guided, or a combination of those. I usually use a wire tip guided, what I call, to engage the papilla. Means once you put the tip in there, it moves freely into the orifice, and you can move your catheter or tome tip into the orifice to stabilize it. That would be engaging the papilla or engaging the orifice. And from there, you can either control with the wire or with the injection. If it's a pancreatic duct, I always encourage to inject, and I'll come to that in a minute, instead of wire guided. Biliary, wire guided is fine. Pancreatic should not be only wire guided, should be injection guided, basically. So reasons for failed cannulation, mostly, I would not talk about equipment sedation. I'll talk about the patient factors, which is the anatomy of the papilla. There's not much time, so a few minutes left, so I'll go through these quickly. Reasons for failed cannulation could be listed here: sharp papilla, up and over papilla, aberrant relationship, separate opening, etc. This is a straight shot. Then sharp papilla, too many folds there. In my experience, usually is the cannula, which were tome is just like take your time to pleat all those folds over your cannula. So I usually use the cannula for these ones. Then there's a up and over. Up and over, you usually see a big bulge over the orifice itself. That means the roof is kind of blown up. So if you go in and if you keep blowing, it's going to keep hitting the roof and never going to go in. Because many times what happens when you are having a trouble cannulating or not getting in, what you do, you just keep blowing it. That's not the solution many times. This is the example of up and over papilla. That bulge right there, you go in, engage nicely, but then you get hung up right there. And if you get hung up right there, the trick to that is inject to get an idea where the duct is going. In this case, you can see it's a kind of a S-shaped. It goes in, goes over the hump and comes down, and you can see that is the axis or line of cannulation. In this case, going further is never going to help. So you have to let the bow go, pull the scope back, flatten that angle, and then eventually pulling the scope takes you into the deep into the duct. So these cases, it's wire guided may not work. So you may have to inject. So injection is not really always a bad thing. So many times that helps you determine the axis of cannulation. In this case, what I'm trying to show is basically what is the axis of cannulation. So moving the big wheel away from me, that kind of flattens the papilla. Then I use the wire tip to engage this papilla. So you will see these a little tip, sometimes little extra 5 millimeter, 2 millimeter, 3 millimeter, just enough to get into that orifice. Once that wire engages, I will move the big wheel that takes my tone, and I see I'm engaged in there, and I pull the scope back. That took me in. I know I'm in the right position, but my wire is not going anywhere. Even though I'm in the right position, it's not a submucosal. I inject a little bit contrast in there, and that tells me it's really up and over papilla. So in that case, releasing the bow and then getting over the hump, and by pulling the scope back helps me get in there. Sometimes there could be aberrant orientation, mean biliary and pancreatic orifice are switched. So got to keep that in mind. That could be problematic, and you keep going into the orifice which you are duct which you don't desire, and it may be just flipped over. There could be separate. You go into the PD, keep going into the PD. Because they're two separate openings and not paying attention that because the septum is coming all the way to the surface of the papilla. This is earlier I showed up a picture here. You can see this ridge that helps me see that where the orifice is. So I use a tome just to lift the folds, and that shows me where the papilla itself is. And then with the wire tip, engage that nicely, gently, because if I keep pushing on it where after engaging with the wire, it's just going to keep flipping into the diverticulum and not help. So once it is engaged, small wheel towards me and gentle maneuvering of the wire, and with the tip of the tome over the wire into the orifice would help me get in there. This is another example. Really, I won't go through that and because of the time. I need to finish it in a couple of minutes. I think I'm already up 2 minutes. But here, this is a papilla completely inside the diverticulum. It's right over there. So I'm using a clip to grab the fold and bring it a little bit straight, but still it doesn't work. Then we use this clip with the rubber band on that. It's called short track. It's made by Microtech. So what we can do is by grabbing that band, you can even pull it further out and put a clip there. So what that does is that gives me a better access to that papilla and kind of stabilizes it too, and then I'm able to cannulate with the wire and tome. This is I think in interest of the time, I would keep skipping those. This is another big mass there. Gotta make sure that you don't keep beating up on this. This is trauma is from the EUS scope. But here, if you look at it, orifice is right there, and gently probing with the wire would take me in. This is another example, plastered septum. Septum comes all the way out. You go in, you cannulate the pancreatic orifice. First, what that does is that pushes the septum up. And then you keep cannulating the pancreatic orifice because you have kind of plastered septum to the roof of the biliary orifice. The trick to that is you use the wire tip only and stay really at the edge of the papillary orifice to push that down and get a wire-guided cannulation. Then double wire technique, won't go through that either. One thing about the pancreatic duct is cannulation. I cannot stress that enough, that when you do if you keep going into the pancreas and then you commit yourself to going into the pancreas, please inject the pancreatic duct before you push the wire. This is the most under-recognized cause of post-ERCP pancreatitis, where wire-guided cannulation is attempted off the pancreatic duct, wire goes into the side branch, perforates the side branch, and patient gets basically post-ERCP pancreatitis. So it's not, contrast is not bad always for the PD. If you have committed yourself, you're going to put a stent and you want to push the wire in there, please put a contrast in there and follow the contrast. Will give you an idea about the main pancreatic duct so you can push the wire in there. This is a study we did, how often really you need a US guided cannulation. US enthusiasts out there, I perform in US. When it's needed, I'll use it for failed cannulation. But EUS is not an answer to marginal ERCP skills. So ERCP skills cannot be replaced basically by EUS. In this study of ours, there every indication was there, EUS biliary drainage was required in only 3 out of 524 native papillas. EUS has a place, but not a replacement of good ERCP technique. So what I do, meticulous primary technique and keep track of my attempts, keep track of my fellows' attempts, and change to alternative technique early. Once you do enough of these, you get the idea when you need to change to the next step, be it a double wide, be it up then stent to the pancreas, be it a pre-cut. So I'll get to the next stage quicker once you have realized that primary technique is not going to work, but that comes with the experience, that comes with the time. So I want to conclude that just because of the time, be nice to the papilla. I think Dr. Waqar Ahmed should be sitting in the audience. Usually he says, अगर तुम papilla को एक थप्पड़ मारोगे तो ये तुम्हें 2 थप्पड़ मारेगा. So be nice to the papilla. If you really are if you keep slapping it, it's gonna slap you back, slap you and your patient. So be gentle to the papilla. And ERCP, some may think it's an acronym for different things, but it is really ensuring really competent practice. It's a less unintentional movements, minimize those, avoid useless movements. They're going to make you successful at cannulation. Study the papilla, talk to the papilla, use the strategy that suits you, provides you the best results, and safe for your patient. Seek help from your colleagues. Really, hardest thing to learn is when to quit, when to seek help. When you learn that, you become a safe and effective endoscopist. I will stop there. Sorry, I'm not there. I wish I could be there and be able to do live cases, but inshallah next time. Thank you so much.
Thank you, Professor Khalid, for explaining and teaching these basic and important tips and tricks of cannulation. So our next talk will be about pancreatic necrosis management, and it will be again by Mustafa Arain, who is working as Professor of Gastroenterology and Advanced Endoscopist at Advent Health Center, Florida, USA. He remains Program Director of Advanced Endoscopy Fellowship in Education at UCSF. He is an advanced endoscopist, and he will be teaching us online these important management steps of pancreatic necrosis. Professor Arain.
I'd like to thank Professor Sher Rahman as well as Dr. Kamran Hassan and the entire PhD organizing committee for this opportunity to present. I apologize I couldn't be there this year, but hopefully can see everybody at the next meeting, inshallah. The topic of my presentation is pancreatic necrosis and contemporary practices. Here are my disclosures. The outline of my presentation is about 3 different sections: acute pancreatitis, classification and management, necrotizing pancreatitis and its management, and then delayed complications of necrotizing pancreatitis. Starting with the classification of acute pancreatitis, hopefully everybody here is familiar with the revised Atlanta classification published in 2013. This classifies pancreatitis into two categories: interstitial edematous pancreatitis and necrotizing pancreatitis. The difference being that in interstitial edematous pancreatitis, the blood flow to the pancreas is preserved so that the organ and the surrounding fat do not undergo any necrosis. In contrast, in necrotizing pancreatitis, there is compromise of blood flow to the pancreas, and that results in pancreatic or pancreatic necrosis, hence the term necrotizing pancreatitis. Why is this important? Because mortality is associated with necrotizing pancreatitis. And if there's infected necrosis, infected necrotizing pancreatitis, then the risk of mortality goes up further. So how do we classify the complications related to necrotizing pancreatitis or even acute pancreatitis? We can discuss these both as localized and systemic complications. Local complications include peripancreatic or pancreatic collections, which we'll talk about more, but also gastric outlet obstruction, splenoportal thrombosis, as well as other organ involvement that is localized to the pancreas. Systemic complications refer to more of a systemic response, which may be limited to a SIRS response, but can proceed to organ failure, which could be described as being sustained if it's more than 48 hours, or transient if it's less than 48 hours, and then involve multiple organ systems, primarily the circulatory, respiratory, and renal. In addition, patients can have exacerbation of their pre-existing comorbidities, which can actually lead to mortality. In terms of severity, I think what we need to think of is the aspect of organ failure. Mild can be considered to be when there is no organ failure and also no complications. Moderate is if there is transient organ failure, so less than 48 hours, or there are complications without persistent organ failure. And the most concerning is, of course, when there's persistent organ failure, which can lead to significant pancreatic necrosis. In terms of localized complications, we can think of those in terms of the timeline. Anything that is considered to be early, defined in this classification system as less than 4 weeks, is considered an acute collection. So in interstitial edematous pancreatitis, that would be acute pancreatic fluid collection, and in necrotizing pancreatitis, it would be an acute necrotic collection. As time goes on and these collections evolve, an acute fluid collection can turn into a pseudocyst, and an acute necrotic collection matures into a walled-off necrosis. Terms we don't use anymore include phlegmon, pancreatic abscess, or hemorrhagic pancreatitis. So how does this really evolve in real time? So here's a patient with an acute necrotic collection with poor visualization of pancreatic parenchyma. Initially, as time goes on, the collection forms a wall or inflammatory rim around it, and eventually would be considered walled-off necrosis. This process can vary over time, but usually we think of the 3 to 4 week mark. Okay, in terms of management of acute pancreatitis, since this does have implications for necrotizing pancreatitis, essentially fluid resuscitation is the first line of management. Without going into too much detail, lactated ringers is the preferred fluid of choice. And in terms of the volume, I'm sure the crowd here is familiar with the landmark study that was published that showed that aggressive fluid resuscitation can actually lead to worse outcomes than moderate. So based on that study, the current sort of guidelines would be about 3 to 4 liters in the first 24 hours, which translates into about 10 mLs per kilogram bolus, followed by 1.5 ml per kilogram per hour maintenance, which leads to about 3,200 cc's in a 70 kilo person over 24 hours. Aside from fluids, IV pain control nutrition, and the role of antibiotics, which I'll talk about, and then importantly, determining the etiology and addressing it. So in terms of biliary pancreatitis, ERCP only in the setting of cholangitis or persistent biliary obstruction, and cholecystectomy during the same hospitalization if possible. In terms of alcohol use, chemical dependence evaluation, and counseling regarding cessation of alcohol. So nutritional support, the key message here is that enteric nutrition is way superior to parenteral nutrition, both in terms of infection risk, organ failure, length of stay, need for intervention, and mortality. It doesn't matter how we get it to the patient. If they're able to eat and drink, that's fine. If not, then enteric nutrition via a feeding tube. NG and G are considered to be the same. Oftentimes, patients just don't tolerate NG tube feedings, and therefore we would go with an NJ tube. The main point being that early nutrition is critical, and enteric nutrition has been shown to reduce the risk of infection. Speaking of which, is there a role for antibiotics? Multiple studies and meta-analyses have shown that for various outcomes, including infected necrosis, there is no role for antibiotics. The initial SIRS response can be very confusing for infection, and there's a tendency to start antibiotics, but there should be a very high threshold for starting antibiotics. And conversely, antibiotics can actually cause harm. They can be associated with C. diff infections, fungal infections, as well as more resistant organisms, as has been shown in more recent studies. So the message here would be to avoid antibiotics. Moving on to the management of necrotizing pancreatitis. The main sort of question always is, what are the indications for intervention and how best to intervene in necrotizing pancreatitis? So multiple guidelines have said that the mainstay for intervention has to be infected pancreatic necrosis, primarily because if the patient is not infected, there is a risk of introducing infection. However, there are other conditions where one needs to intervene. Those include ongoing organ failure, which just isn't resolving. These patients are often in the hospital for several weeks and just not getting better. In those situations, there may be a role for intervention, again, trying to delay it as much as possible. And then in the setting of sterile necrosis, usually once the collection has walled off, typically more than 3 to 4 weeks since the onset of the acute pancreatitis, there are specific situations where intervention may be necessary, and those include gastric outlet obstruction, intestinal obstruction, or biliary obstruction, persistent symptoms, pain, just not feeling well, unable to eat much. This is somewhat controversial in my mind, a disconnected duct where we feel that the duct leak is leading to an increasing collection that is not going to resolve on its own. Maybe a consideration, however, that is somewhat controversial. In terms of timing of infection, it is important to know sort of the natural history of both acute pancreatitis and necrotizing pancreatitis. So we have that initial SIRS response at the onset of pancreatitis, and often after that, there is a lull in the situation where the patient either gets better, but not to the point that they can leave the hospital, or they may get better and leave the hospital and come back. And in severe cases, they just persistently remain ill. However, infection on average doesn't occur for several weeks. In this study of over 700 patients, multiple centers, the mean time to presentation with infection was about 4 weeks. And mortality related to infection doesn't occur till about 7 to 8 weeks. So these are good numbers to keep in mind. Acute response immediately, delayed sort of presentation with infection about 4 weeks, and infection-related mortality in about 2 months. So this is a long, drawn-out process. What are the signs of infection? This can be very obvious, such as gas in the collection, acute sort of clinical change in the patient's status, onset of fever, sepsis, organ failure, but sometimes it's not as clear-cut. air in the collection can also be from a fistula from the GI tract, and the patient may actually be doing well. That's really an auto sort of cyst gastrostomy or cyst enterostomy by the body, and the patient starts getting better without any need for intervention. What is the role of aspiration? Some guidelines do mention it. However, this is also somewhat controversial because there are both false positives and false negatives. And generally speaking, if the suspicion is high enough to intervene, then one needs to intervene. And since we can get both false positives and negatives, the general consensus tends to be not to just aspirate percutaneously. In terms of management, sort of the principles are delay, drain, and debride as necessary. So if we think about it, nowadays the approach that is preferred would be on the right side, which is the endoscopic approach. If the collection is accessible through the stomach or the duodenum, the ideal approach would be to have transgastric stents placed, followed by necrosectomy as needed. In situations where that is not feasible, the preferred approach would be a percutaneous approach, ideally through the retroperitoneal space rather than coming anteriorly, as this may allow subsequent necrosectomy through this tract. This would be the case either if the collection is far away from the stomach, or if the collection is immature and doesn't have a wall around it and one needs to intervene. So once the drain is in place, then both endoscopic, percutaneous, or surgical debridement can be performed. And if either of these endoscopic or percutaneous approaches fail, then we move to surgery. What is there to support this approach? Well, multiple randomized studies have now shown that endoscopic intervention is superior to surgery, whether that's open surgery, whether that's step-up surgery following a percutaneous approach, or if it's laparoscopic surgery. And some of the key findings here are reduced risk of fistula formation, and in one study, reduced cost associated with endoscopic therapy. So if we think about it, so the other question that comes up is the approach for the type of stent that is used. So if you look at some of the guidelines, they would suggest that based on resources as well as availability, one can go with either plastic or metal stents. If the collection is very large and there's anticipated need for necrosectomy, then maybe consider doing aluminum-opposing metal stents. For smaller collections or when stents are just not available, then plastic stents can be considered. Once we do place the stents, then it's a matter of seeing if the patient is doing well or whether we should consider necrosectomy. Here's an example of a necrosectomy being performed. The patient has aluminum-opposing metal stent. Oftentimes, whether it's the plastic stents or metal stents, there'll be intervening necrosis, which initially can be hard to remove. So it requires a lot of patience. Multiple devices and tools have been tried. In my personal experience, snares still tend to be the best device for this. We gradually remove necrotic tissue and just keep going back into the collection and remove the necrotic tissue and then deposit it into the stomach. This patient actually had 2 entry points. This video has been edited, obviously, and this entire procedure took over 2 hours. A question often fellows will ask is, how long do you spend? And the answer is, it depends on the patient's clinical picture as well as the overall sort of schedule in the day and what needs to be done. Usually the first half an hour is really just spent making space, and then we can make some significant progress. What is the role of urgent endoscopic drainage? So in some studies, it has been performed in less than 4 weeks, and these are usually patients who are sick but appear to have a walled-off collection. And what's been shown is that it's safe to be performed with no significant increased risk of complications. The main thing is that these patients are sick to begin with, so they may have poor outcomes, not necessarily related to the intervention, but more so related to their disease. So if there is a walled-off collection, even at, say, 3 weeks or less than 3 weeks, it may be safe to perform endoscopic drainage and subsequent necrosectomy. So coming to this issue of metal versus plastic stents, this is really interesting because there was a lot of enthusiasm and excitement and push really for placement of metal stents. And as time goes on, and when the sort of the fever kind of settles down, people start using sort of more of a scientific approach. And when that is being performed, multiple studies have actually now shown that there is no difference between metal and plastic stents in terms of outcomes. This meta-analysis that was published just this year shows no difference in clinical success, technical success, overall mortality, recurrence rate, number of procedures, long-term complications, need for surgery or percutaneous drainage, and adverse events. The only difference was that the shorter duration of stent deployment. So again, in resource-restrained environments, plastic stents continue to be the mainstay, and one could argue that if we are talking about resources, potentially that may be the case in resource-rich environments too. So overall, how do we manage these patients? Medical therapy followed by deciding whether or not the collection is encapsulated. If it is, then we can go with the approach either through the stomach alone, or we can combine that with the percutaneous approach. If it's not encapsulated, then we have to go percutaneous, and if all of these are failing, the patient's getting sicker, then we go with surgical necrosectomy. A brief mention about delayed complications. These include disconnected pancreatic duct syndrome, diabetes, exocrine pancreatic insufficiency, mesenteric vessel thrombosis and occlusion, outlet obstruction, and then not to forget psychological effects for patients. So disconnected pancreatic duct syndrome implies that there is a disconnection, complete separation of two parts of the pancreas, typically associated with intervening necrosis. So if an ERCP is dead, you just cannot see upstream duct. In this situation, you can see upstream pancreas on the cross-sectional imaging with a slightly dilated duct, but there is a big gap in between. These patients can present with recurrent collections, persistent fistulas, and progress to chronic pancreatitis. More commonly than not, though, these patients are asymptomatic. This is different from what is a pancreatic duct leak, which is where the duct actually has a leak in the pipe, but essentially you can still get across it. And these patients can present with ascites, pleural effusions, other kinds of pancreatic collections such as pseudocysts, but you can actually treat these patients by placing a pancreatic stent, as opposed to duct disconnection where a transpapillary stent will not make a difference. So in the era of metal stents, one of the issues that's come up is what should you do once the collection is gone? Should you leave these metal stents in place, or remove these and put in plastic stents, or just once you're done, remove the metal stents and leave the patient be? And what's been noted is that there is a small but increased risk of recurrent collections if you don't replace stents. Mostly this is retrospective studies, but this randomized trial sort of categorized patients in both placement of plastic stents or not replacing the metal stent with plastic stents, and the rate of a recurrent collection at 1 year was 25% in the no stent group versus 13% in the stent group. So the general sort of guideline is that if a patient has had metal stents placed, see if you can look for a disconnected duct, and if so, place double pigtail stents. If, on the other hand, there is no obvious disconnected duct, then you can leave them without stents. In the setting of plastic stents, this is actually an easy decision-making process, that if your level of suspicion is high, you can just leave those stents long-term and not worry about those stents. Rarely these stents do cause complications like a fistula into the colon, but most commonly these patients do well with these stents left long-term. Also, these stents may not necessarily stay in place. They may just migrate on their own, and the patients may do well. So it's not a 100% correlation between complications and stent placement. So to conclude, in terms of acute pancreatitis, terminology and classification matter. Generous hydration, we don't want to be overly aggressive. Enteric nutrition matters. There's no role for antibiotics. For necrotizing pancreatitis, an endoscopic approach is preferred. Awareness of disconnected pancreatic duct syndrome and long-term complications. In addition to disconnected duct, diabetes, exocrine pancreatic insufficiency, long-term pain, and quality of life issues. With that, I'll conclude, and thank you for your attention.
Thank you, Professor Mustapha, for a detailed talk on a difficult topic. So our next talk will be associated with pancreatic diseases. It will be pancreatic cyst management, and this talk will be given by our guest speaker, Professor Syed Faisal Japri, who is Professor of Gastroenterology at Overland Park, Kansas City. He is advanced endoscopist with special interest in endoscopic management of pancreatic diseases. Professor Japri.
Thank you very much. I want to thank PSG for giving me the opportunity today to talk about pancreatic cysts. This pancreatic cysts has completely changed our practice in the last 15, 20 years. I honestly spend about at least an hour every day just reviewing CT scans and triaging patients on what to do. So this has just become pretty transformative for us. So this is what happens. A patient goes to, in the Western world at least, even if you go and stub your toe, you get a CT scan. Or, they're done for various regions, a AAA follow-up, renal, kidney stone, or whatever. So they do these CTs and they get these findings of a lesion in the pancreas. So they go to their primary care doctor, and the primary care doctor tells them that you had that CT and they found a lesion in your pancreas. What the patient heard is that they found a lesion on my pancreas and I've got cancer. So now he's got all of this anxiety going on, and now our job is to kind of clean up this mess that has been created by this incidental lesion. So you can see there are multiple kinds of cysts, and our job now is to kind of clarify this picture of what these cysts are. I'm going to spend some time initially just kind of defining what these cysts are, and then kind of do how I manage them. So the incidence of pancreatic cysts, at least in the Western world where everybody gets a CT scan, is significant. Up to an average of about 15% of CTs would show some sort of a cystic lesion in the pancreas. And as you grow older, in the 7 or 8 decades, the incidence is up to 40 to 50%, depending on the study you look at. So it's an overwhelming issue, and it has taken quite a bit of our time figuring out what to do with these cysts. So before we go any further, I want to just talk about a few facts about pancreatic cysts. So as I said before, the overall prevalence of pancreatic cysts in general population is around 15%, but it can vary from 2 to 38%. But the risk of pancreatic cyst being malignant at the time of diagnosis is 0.25%. Guess what the incidence of cancer in Barrett's esophagus is? 0.5%. And we don't take this as seriously, or a colon polyp turning into cancer. So we are playing in the same field, but the anxiety levels are much different. The annual rate of a conversion of a cyst found incidentally is about 0.24%. Our job really is to figure out which ones are the high risk lesions and which can be just kind of put on the side and say, okay, we will continue to monitor them. So just to go over the types of cysts which are present, you can divide them into inflammatory fluid collections, which Mustapha already went through, and I don't want to spend any time on that. Some non-neoplastic cysts, which is some of them are very rare, true cysts or lymphoepithelial cysts. But the most bulk of the cysts are these pancreatic cystic neoplasms. And they can be divided into 4 major categories: the serocystic neoplasm, the MCNs, the mucinocystic neoplasms, the IPMNs, and the solid papillary neoplasm. That kind of encompasses all of these neoplastic cysts. So here you are, the patient comes to you, and you are shown the CT, and you say, what is this? Now you've got to figure out how you're going to progress to this point. So when a patient comes to me like this, these are the questions I put to myself. And I should say that every one of us should be looking at it when we do that. So number one question, what is it? What do I do with it now? Do I investigate this anymore? How do I investigate this? Do I do an MRI? Should I do an EUS next? How do I follow these lesions going forward? And what kind of information, if I do an EUS, what kind of information should I be looking for? And then define this lesion further. And then once you've defined these lesions, am I sending to the surgery? Are they continuing? I will continue to monitor these cysts, or what's the long-term follow-up? So just to define a few of these lesions in just a little bit of time. So the serous cystic adenomas are completely benign, no risk of malignancy. They're more common in women than in men, and usually found in the sixth decade of life. And they have these classic imaging findings of microcystic or a honeycomb appearance, and the pathognomonic finding is the central scar. So any of these are found, most of these, if these findings are found, you can be rest assured that you're dealing with a serous cystic adenoma, and may or may not need much workup done. Because if you do an EUS, this is how they look. They look like this honeycomb on the right, or these macrocystic, but mostly fibrotic appearing in this cyst with a mix of macro and microcysts. And we often don't even do any biopsies, because when you do a biopsy, there's a very high vascular lesions, and you just get blood back. So honestly, there's no point doing an FNA for these lesions. The findings on CT and EUS are diagnostic. And once you make this diagnostic, you can rest assured you're not missing cancer here. Pseudopapillary cystic neoplasms are rare, but they are almost always in women. And they're usually found in the younger women, between the 20s and 40s. This is, if you find a young woman presenting with a cyst, almost always they'll turn out to be a pseudopapillary neoplasm. But you still have to kind of define them, and the CT findings are a well-demarcated mass with a solid and a cystic component, and they have a thick capsule. The cytology, when you do these, show a myxoid stroma. And one of the board questions is the stain positive for S100. So they have a significant malignant potential. So once you make this diagnosis, they should be referred for surgery, because there's no reason to follow these again and again, because eventually the answer is you have to do surgery on these. The CPENs or the CNETs, or the cystic pancreatic neoplasms, they are found incidentally, almost always non-functioning. They are also rare, but found again in the sixth decade of life. They are also thick-walled. And once you find these and they are in large enough size, the treatment is still proceed with surgery. And this is how they look on EUS. This is the patient I just saw last week. You have thick-walled cystic lesion right here, and you do an FNA on it, or an FNB, whatever you want to do. You see these round blue cells, which are classic neuroendocrine tumors findings. So once you make this diagnosis, you should get your surgical team involved and talk about surgery for sure. Mucinous cystic adenomas on the other side are these almost always in women. You see this lesion in a men, it's not an MCN. Almost always women, usually in the fourth and fifth decade, almost always found in the body and tail of the pancreas. The findings are usually, they are unilocular, can be mild septation, but they are almost always unilocular and found in the body and tail of the pancreas. And there's no duct communication with the main pancreatic duct. They have an ovarian stroma when you do a biopsy of these lesions. And a third of them do have a malignancy when they are resected. And therefore, when you make a diagnosis of an MCN, the treatment for that is referral to a surgery. Now come to the main bulk of the cysts that we see are these IPMNs. They are the most commonly found cystic lesions. Again, there's a slight male predominance, usually in the sixth and seventh decade again, and they do have a risk of malignancy. Now, that risk of malignancy varies on the types, and I'll kind of define them here. So there are four types of IPMNs. So the first one is the branch duct IPMN, which arises from one of the side branches of the pancreas, and usually small cystic lesions, either single, one, two, or could be like a bunch of grapes lying in next to the pancreatic duct. They have a low risk of pancreatic malignancy, but they are not completely benign. The risk of them having a malignancy after 5 years is about 3%. But if you follow them for 15 years, the risk is up to 15%. So these are the ones you can't ignore all of them, you have to follow some of them. Main duct IPMN has the highest risk of pancreatic malignancy and highest risk of progression, and this is basically how they look. The main duct is markedly dilated, and with some side branches which may be dilated too, but the main feature is this dilated main pancreatic duct and an atrophic appearing pancreatic parenchyma. There can be a mix of these two. Either it could just be a partial pancreatic duct dilation, or it could be a main duct along with multiple side branch pancreatic ducts. They also have a malignant potential and do progress over time and have to be watched very carefully. This is how these cysts look on CT scan, and these are the pathognomonic findings that you would do in endoscopy. So when you suspect main duct IPMN, always look at the ampulla, and you can often see the mucus pouring out of it, what's called a fish mouth ampulla. When you do an EUS, you can see these mucus materials floating around in the pancreatic duct, and if they are partial duct, you can see the main pancreatic duct in picture C, and then there's a dilation of the pancreatic duct in the backside. They can also be just segmental main duct IPMN, in which could be a normal duct followed by a dilated duct distally or proximally. So there can be a variable thing. Just keep in mind that main duct can have all these features, not just a dilated main pancreatic duct. A clinical feature that need to be kept in mind here is this mural nodules. This is where most of the malignancies are happening. And if you see this in EUS and with an FNA, should be directed towards this mural nodule. And they can depend, the malignancy also depends on the size of these nodules. So just watch these, target your EUS biopsy towards this lesion. So how good are these imaging studies? The CT has an accuracy of about 24 to 61%, especially if there's some pathognomonic findings of a dilated pancreatic duct or a central scar that you see. Then you can say these CT is an accurate, very accurate study. MRI, on the other hand, is more accurate, less radiation exposure, and it can define if there's a branch duct communication. EUS has the highest sensitivity of all these tests. Alone, EUS is 84% good at diagnosing branched cystic neoplasm, but if you add a fine needle aspiration, they're up to 90%, especially if you do a fluid sampling. So when do I do an EUS? I look at these CTs and I'm looking for high risk and worrisome features. If you see these high risk features like a duct which is greater, a size of 3 centimeters or more, a dilated duct more than 10 millimeters in size, or a mural nodule, if I see these, I would do an EUS, confirm the findings, and then talk about surgical resection on these. But they've been divided into these worrisome features as well, which are not classic for malignancy, but are high risk lesions. So cyst size more than 2 centimeters, pancreatic duct dilation, abrupt termination of the duct, new lymphadenopathy, and in the recent guidelines, new onset of diabetes, and a family history of pancreatic cancer. So, and then I do an EUS, and the typical studies I do is a CEA, amylase, glucose, and cytology. Rarely I would do a biopsy as well, but often there's not much helpful. Most of the information comes on an FNA. Rarely, if I see a nodule, I'll biopsy it, or if I see an abnormal feature, I would biopsy it. So cyst fluid analysis can kind of define most of these lesions if you put these 5 factors in mind. So a serous cystic adenoma will not have a viscosity if we biopsy it. A mucinous will have a mucoid appearance, and an IPN will have a mucoid appearance. Pseudocyst, again, no viscosity. Amylase in a pseudocyst will be high, and a branched and an IPMN will be high. What it basically is telling you is there's a communication with the pancreatic duct. CEA in mucinous has been found to be very helpful in defining mucinous versus non-mucinous cysts. So they're high in MCNs and IPMNs. And the new kid on the block, well, not really new, but been around, has been very helpful in making a diagnosis of mucinous versus non-mucinous, is the fluid glucose level. And cytology can be helpful in MCNs and also sometimes in IPMN. So the main components are to look at the viscosity of the fluid, CEA, and amylase, and glucose. So how good are these tests? So Bill Brugge, about 20 years ago, defined that if you make a cutoff of 192 for a CEA level, you're picking up about 56% of mucinous neoplasms, and it is 91% specific. This has become pretty much the standard in using CEA levels. That doesn't mean that a low CEA level below this cannot miss it. Yes, there is some miss rate there. And the higher the number is, usually means there's a higher risk of a mucinous level. But there is no correlation between the level and malignancy. Glucose, on the other hand, if it's less than 50, has an 87% specificity in finding mucinous lesions. And when you combine CEA and glucose together, you are almost certain at 95% that you're dealing with a mucinous lesion. So some more analysis which has been done are these DNA analysis. The first study for DNA analysis, the PANDA study, came out from one of our own, Asif Khalid, almost 15 years ago, and he said that if you have a KRAS mutation with allelic loss, it has a 96% specificity for malignancy. Though in clinical practice, it really didn't pan out as well. We started doing it, did for about 10 years, and it's kind of fallen off favor because it's very difficult to get these DNA analysis, and then once you do it, it's difficult to analyze that, and often insurances don't pay for it. So it's kind of fallen out of favor. Recently now they've been doing next-gen gene mutations, and what they're looking for is a KRAS mutation along with GNAS mutations. And the studies which were done a few years ago are showing up to a 90 to 100% specificity for this. Again, the only two companies which do it, and also they're very expensive. So usually done in academic centers where the surgeon is asking you for more data to kind of give you or the oncologist is not ready to treat them. So those special situations, I think it has some role, but in clinical practice, a very low role. So here we are. We've defined all of these lesions, and now we have to figure out what's next. What do we do now? So we still have, we figured out the serous neoplasms, we're not sending for surgery. MCNs, we are sending for surgery. SPENs, we are sending for surgery, and CNETs, we're sending for surgery, or ablating if they're small. But the bigger bulk is still the IPMNs, and we're still deciding if we do surgery, leave them alone, and to follow. So because of this confusion, multiple guidelines have come in, and the first one actually came out from my Japanese colleagues called the Fukuoka cystic guidelines, and they have had multiple iterations, and the last one actually came out last year. But basically, they're dividing these cysts and looking at some very specific features within them, and then size of this cyst to define how you follow them going forward. So if the patient presents with obstructive jaundice, has a solid component within the cyst, and a dilated duct which is greater than 10 millimeters, it's a no-brainer. They need surgery. There's a malignancy sitting somewhere there. So you send them to. But if they're not, then you start looking at these worrisome features, which are, again, I mentioned earlier, is history of pancreatitis, a size greater than 3 centimeters, or a duct which is greater than 5 to 9 centimeters. These are all worrisome features. You start thinking of malignancy, and now you've got to define, and if any of these are not seen, you do an EUS, FNA, and any of these kind of further define them, send them for surgery. Now the problem comes if you don't have any of these features, and which is the most common scenario, you just have a cyst, and now you have to define on the size of the cyst what the next step is. So cysts less than 1 centimeter, the recommendation by Fukuoka was to follow them every 2 to 3 years with a CT or an MRI. Larger cyst, you follow them a little more closer every 2 years, and then think of increasing the interval. Bigger cyst, 2 to 3 centimeters, much closer follow-up, 3 to 6 months follow with these, followed by an EUS and MRI alternatingly every 3 to 6 months. And if they're greater than 3 centimeters, they should be considered for surgery at that time. The ACG, AGA, and the European societies also gave their guidelines over time, and they're slightly different than the ones, and I just want to point out a few ones. What AGA says is that you find a cyst which is less than 3 centimeters, do an MRI for 1 year, and every 2 years for 5 years, and after that you can stop following them. So that was the big difference on AGA side, which is not in any other guidelines. ACG is continuing to follow them, and it's just the difference between the consensus guideline or the Fukuoka is the difference in how you follow them. So ACG says MRI in 2 years for smaller cysts, and then increase to up to 4 years times 4, and then you kind of just increase your interval depending on how you feel about it. Larger cysts, again, you follow them a little more closely, and then follow them for a few years, and then you can extend the interval. EUS, on the European guideline, the only difference is they say that you do an EUS, follow them aggressively initially, is what they're saying. Follow with an EUS or an MRI every 6 months, and a CA19-9 level, which is not in the Fukuoka guidelines earlier. But they say that you follow them, and if the cyst becomes more than 4 centimeters, then you send them for surgery. There's slight differences, but the basic concept is about the same. Follow these closely, and then depending on how fast they're growing, increase the interval. The last guideline, which just came out last year, again, defining the same things. They're defining into high-risk features and worrisome features. couple features which have just been added now is the presence of new onset of diabetes and a thick enhancing cystic wall, and the size of the neural nodule. Greater than 5 millimeter neural nodule, high risk for malignancy, send them for surgery. If they're less than 5, follow them. And the cyst growth. Now, if you see a cyst growth of more than 2.5 millimeters every year, that is considered a worrisome feature. Those are the ones you need to be following more closely going forward. So now we have defined these lesions. Not what do we do? Send them for surgery. Yes, I think that's the right answer, but you have to consider what's associated with surgery. These are not benign procedures. A Whipple has a mortality, even in the best of hands, of about 1 to 3%, and a morbidity of 20 to 40%. It's a life-changing surgery. The patient is never the same after you have a Whipple. Or there's an option of doing cyst ablations. This is reserved for patients with advanced age who are not surgical candidates. That's an option available, which has been available for about 10-15 years. There are multiple ways of doing these ablations. The first studies came out of Indiana University was for just ethanol ablation alone at a 61% complete resolution, but at a risk of 8% of developing complications, which predominantly is pancreatitis. Ethanol plus paclitaxel is about the same as well, with complete resolution in about 54%, with almost as high a risk of complications. And paclitaxel alone came out later on, and it said there was a 30% resolution on initial studies with a small risk of complications. But then the CHARM study came out last year, and it says that if you have a complete resolution in these cysts up to 87% and a partial response in 93% of them. So, and a much, much lower risk of pancreatitis. So there's some food to thought, something you can keep in your mind about chemoembolation of these cysts. I don't think I'm going to spend too much time, but this was just here because the way we're starting to use it, as I said, I review about 6 to 10 CTs every day for finding out, and that takes a lot of my time. So we're using AI to kind of help us through this, and what we're doing is using these multiple terms which are the radiologist uses it, and then kind of define our own pathway. But this time, in order to use my time, I'm using my nurse navigator to help me define these and find the more higher risk than which are then seen by us or our surgical colleagues. So I'll stop here. Thank you very much. I'm over time, and I'll answer the questions later on. Thank you.
Thank you, Professor Japri. I will request Professor Ghayasun Nabitev to join the panel of expert as he is chair of the. So our next talk will be by Professor Saad Khalid Niaz. He does not need any introduction. He is Professor of Gastroenterology, Advanced Endoscopist, founder and CEO of state-of-the-art SIAG, and he is also President-elect PSG. He is going to talk about chronic pancreatitis. Professor Saad Khalid.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Professor Sherman and Dr. Kamran, for giving me this opportunity. I've just been told that I need to cut the talk by a few minutes, so I may just go through a little quicker. I would like to congratulate the organizers for organizing a very well-planned and well-organized conference, so hats off to them. So we'll probably just look at what causes chronic pancreatitis and what are the issues, why do the patients have pain, then endotherapy for pancreatic stones, endotherapy for pancreatic strictures, endotherapy versus surgery, and role of EUS in this management. So you're all familiar with the reasons, and it's very important while you're treating chronic pancreatitis. It's not an easy thing to treat, all of us who treat it, that factors like smoking and alcohol need to be addressed. And while there are so many causes, hence there are multiple issues that you need to deal with when you're doing endoscopy for such patients. What are the indications for therapy? Obviously, patients who are symptomatic need treatment. Failed medical treatment when you've given them initial pain management, although when most of the time we are actually going, patients who are symptomatic now come straight to definitive treatment, whatever is available. imaging showing obstructive stones, strictures, pancreatic duct dilatation, amenable and fit for surgery or endoscopic therapy. And associated complications, which include CBD, strictures, pseudocyst, and MPD disruption. There are a lot of things that you can do endoscopically. You can manage pancreatic side of the problems. And of course, you can also treat endoscopic pseudocyst. You have biliary strictures that occur because of this. And also for pain management, you can use EUS for celiac block or neurolysis. ESWL is included here because most of the time it's combined with ERP. So what causes pain? Not going to dwell if most people here are familiar. So who are the ideal candidates for endoscopic therapy? So stone burden, single dominant stone or solitary calculus in the head, stone location, head and neck or proximal body, radio-opaque versus or radiolucent. It depends on, obviously depending on whether they are radio-opaque or radiolucent, you will plan your treatment. PD stricture, if it's a single stricture, yes, it's easy, relatively better response. What makes candidates less ideal? Multiple strictures, multiple stones, calcification, and pancreatic tail involvement. So management, what can we do for pancreatic stones? Pancreatic stones that are less than 5 mm, we can actually, especially if they're in the proximal pancreas, you can remove them endoscopically, and quite often that is what you need to do, but we don't see that very often, at least not in our practice. More than 5 mm, you have the option of ESWL combining with ERP or doing spyglass and pancreatoscopy as well as EHL or laser. For radiolucent stones, you obviously ESWL and for ESWL, you need to be able to identify them. And so practically, if you have spyglass, then that's probably the best option. Mechanical lithotripsy is best avoided. Unless it's a stone and you've got a nice open duct. Pancreatic sphincteroplasty is also now not uncommon. So once you've got a nice size sphincteroplasty and you want to go and take a stone out and you have a trapezoid basket, which is what I generally use. I mean, I don't use any other for lithotripsy. So what's recommended for stones that are more than 5 mm? Then I think if you have the availability of ESWL, then you can use ESWL, break the stones and then remove them if they don't get out of the duct themselves, because after ESWL, sometimes the fragments become very small and they can literally become like debris and come out. So if there's incomplete fragmentation or coexistent ductal stricture, you would obviously need to do something endoscopically. Is ESWL safe? Generally, except for if not done for the right reason, i.e. tail. You don't use it for tail disease, and pancreatitis is a risk. In our experience, we have so far not had any pancreatitis in our patients, but this has been reported. There's very good results. I mean, this is a recent study that showed complete stone clearance, 73%, and complete pain remission, 70%. And this is a fairly long follow-up. What about spyglass? Again, there are very good results for clearing patients who have just stones. You can go direct visualization. You need EHL. I personally feel EHL, especially in pancreatic disease, is better because you're less likely to damage, although there are advantages of laser as well. technical success has been shown to be good. And so direct visualization allows precise stone targeting and reduced ductal injury, detects radiolucent stones which can be missed otherwise, and confirms ductal clearance. It requires expertise, it's very expensive, and it can be very difficult. And you need to have a good opening and a good dilated duct to be able to do it. I'll just skip this one. There is enough data now to show in meta-analysis as well as long-term studies that the spyglass and EHL or laser are effective treatment for pancreatic stones. However, for Pakistan, I think it's the cost that would be very difficult. I'm going to skip this. And endoscopic management of pancreatic duct strictures. What can we do for strictures? This is where the difficult problem is. The response is very variable. In some patients, there's magic response. In the others, there isn't. The important thing is there should be a significant dominant PD stricture. And with the larger the PD size, the better the response, at least in our experience. Endoscopic treatment typically involves pancreatic sphincterotomy, stricture dilatation, and placement of stents. The number and size of stents depend on the stricture's severity and upstream duct size. Duration in responders, stents should be maintained for at least 1 year. We've had patients who we've left actually longer than that, so who clearly do not want to have surgery or are not fit for surgery, and they come and get their stents replaced as and when they need them. Effectiveness, early response, as I said, is quite often magic, but it only occurs in 2/3 of the patients. So what is a refractory PD stricture? The dominant stricture that persists or relapses after a single 10 French pancreatic stent placement indwelling for 1 year. So you've left a 10 French stent, you bring the patient back, and the stricture still is there. What options do you have? You can dilate the stricture, put multiple stents, you can put metal stents. I've placed this pancreatic, fully covered pancreatic stents in a few patients, and personally, we've not had very good results with the bumpy, and that's the only one that I've used. But patients find out now from different relatives living abroad, and they come and suggest these things, or people living abroad actually suggest. Quickly, just share some cases. This is a patient who had an injury. You can see there was pancreatic duct disconnection, leakage. So we went in from the main papilla, put a stent. The patient's response is fantastic. Although you're not actually draining the whole duct, but even if you drain the proximal duct or proximal to the leakage, you get a very good response. Let's hope this video works. So you can see this is a patient who has a pancreatic leakage. How do I improve? And the same patient. No, I'm sorry, they both are running. So can we pause it somehow? Because I can't use this here. Okay, that's better. So on the left, there's a patient who had a leakage. We couldn't cross, and we just put a stent proximal to the leakage, and the response is fantastic. On the right, as you can see, this was a leakage, and we managed to pass the wire. That you can see there. The wire then goes into the pancreatic duct, and then we actually put a pancreatic stent, and the response is very good. I'll skip this one. We've already seen this. So what do you do with pancreas divisum? So you can actually do a pancreatic sphincterotomy, minor papillary sphincterotomy, put a stent. So when we are doing now chronic pancreatitis, especially in younger patients, I'm actually looking at minor papilla first. So I go in and I'm actually looking, as I'm entering, I'm looking at minor papilla. Quite often you see a little bit of leak, pancreatic juice coming out. As soon as you see that, you know that the problem is more likely to be there. So this is our practice now. We look for minor papilla as we are entering. Again, I think this is another minor papilla. So what about EUS? Can it help? Yes, if it's normal anatomy and we can't get access, we can do a rendezvous or we can do an antegrade stenting. And in patients who've already had surgery, you have multiple options. You can do transmural stenting. You can also pass guide wire and dilate the anastomosis. So you have multiple options available for those patients who are either not fit for surgery or are considered not technically fit for surgery. So EUS plays a role now in patients where we previously didn't have that. Transmural stenting is a very useful option. You can see here, the pancreatic duct is dilated, the wire can't go through. Well, what you do is you put a stent, and through this stent, you can actually now get your spice scope and go in and look at the pancreatic duct, break the stones. So the options have become very many. Management of pain in chronic pancreatitis. So what can we do? Identify chronic pancreatitis, stop the aggravating factors, alcohol, especially smoking. If the pancreatic duct is dilated, you have endoscopic versus surgery. If the pancreatic duct is not dilated, then you have a problem. And of course, depending on what options you have, you'll go for. Now, the celiac plexus block or CPN both have been done in patients with chronic pancreatitis, and results are pretty similar. Pain relief, and it's very important when you're doing celiac block that you have to tell your patient the response is going to be about 50 to 60%. And I tell my patients, look, I don't know whether you're going to be in 40 or 60, but this is a good option if it works, but doesn't work always. And it's very important to tell your patients, otherwise you'll have 4 out of 10 patients who will be disappointed. The technique is very simple, very easy to do, and most people can do it. Surgery, of course, has been there much longer, and the concept is similar. Remove the stones, drain the pancreatic duct. Most of the surgical studies were done, as you can see, a little while ago, and have shown, the earlier studies showed surgery to be much better, but then at that time, ERP was not as advanced as it is today. The studies did not target total duct clearance or structure in this particular case. And better and advanced endoscopic techniques now obviously need to be taken. This is a borrowed slide from Khalid Hassan. So ERCP or ERP has made a lot of progress. Total pancreatectomy and islet cell autotransplantation is also available in the Western world. And is useful for patients who have diseases that with normal duct pancreatitis, chronic pancreatitis, or thin ducts, where you cannot offer them treatment, and hence this has been used and it's useful. There are adverse events like they are for ERCP generally. There's just one quick picture that I want to show, movie that I want to show you. We've actually sent it to, I think, ASGE. This is a patient who had pancreatic stones. We did a sphincteroplasty and wanted to take the stone out. This is my colleague. The basket got impacted, and they thought what they could do, and we used APC to cut the basket wires, and eventually removed the basket and saved the patient from a very difficult, and ourselves from a very difficult situation. So you have options even if you get stuck, I think it's important to know what options you have and how to use them. In conclusion, the care of chronic pancreatitis is complex and should be undertaken in high volume centers, multidisciplinary settings with experienced gastroenterologists, pancreatic surgeons, and radiologists. Older randomized controlled trials suggest surgery is superior to ERCP. However, endoscopic therapy has advanced dramatically, and the last study, ESCAPE trial, that compared the two modalities again had most of the patients were stones, and so I'm not sure there was no arm looking at the SPY, which obviously is part of our treatment arms. Ancillary support for pain specialists, psychologists, dietitians, and social workers would help in managing these difficult conditions. I think it's very important these patients come for your ERCPs. We think it's not a problem, but coming every year for an ERCP has its effect. They've been on high doses of opioids, and so there's a lot of issues other than the pain caused by the disease itself, and that needs to be addressed. A lot of our patients have been told not to eat. Practically, we are a society which thrives on the food that we had in Namak Mandi, or we had on the inauguration day, and those kind, people having those kind of foods. You stop them from having everything, you're going to have a very malnourished patient. Thank you very much.
So our next speaker is a very vibrant personality, and he's our guest speaker, Dr. Nadeem Tihami, who is working as consultant in hepatology and pancreatobiliary medicine at University Hospital Southampton NHS. He is advanced pancreatobiliary endoscopist, and he will talk about biliary stricture management. Dr. Nadeem Tihami.
Thanks, Yusuf. Thank you to the PSG organizing committee. I'm extremely grateful, and it's truly an honor to share this podium with such accomplished professionals. Can I have my slides, please? The first one. So the topic, I think, is such that I guess most of the audience would have come across this at some stage in their career. And I'm sure you get plenty of opportunity of managing such patients in future as well. I have no disclosures at this stage other than obviously my cognitive bias, and also I do not practice here, so therefore my perspective is from overseas. I would like to take this opportunity and pay a tribute and a massive thanks to the whole PSG committee and all my dear friends, colleagues who have contributed significantly to the development of the society, to the trainees, and obviously the trainees overseas as well. And we've learned a lot from you guys, which has helped us in managing these patients overseas. So I'm truly, truly grateful. So the agenda of my talk is I'm going to take you through some diagnostic workup, which I guess is standard in across the continents. Then I'm going to suggest some therapeutic interventions. Now, I guess most of you are already aware of what is available and what is on horizon. I'm just going to take a slightly different tack because most of these interventions are available and you have got a fair understanding of how to approach these. But hopefully by the end of the talk, you will have a bit of a clarity in terms of decision making, especially when you are considering what all these new options are. I will have some case vignettes to share, and then there are some recent guidelines which I would like to share with you all as well. Now, the reason I have this slide here is because the beauty of our discipline is that it's a dynamic field. The evidence is evolving. What we learn today may not be true tomorrow or the day after tomorrow. So therefore, we have to have an open mind. The presentations of the similar pathologies can be different in different parts of the world as well. So what we know now may not be true tomorrow. So it's really important to have that open mind. This is a rules book that I tend to follow, and I think it is something which has helped us tremendously over the years. We really want to connect with our patients. We really want to ask them what are they going through and how have they come to us. We do not manage images, we manage patients. So we have to take a good history from them. The other thing that we want to do is as far as the strictures are concerned, biliary strictures are concerned, assume they're all malignant unless proven otherwise. We want to rely on invasive imaging, other modalities as first protocol, because we don't want to kind of jump with our endoscopic or other invasive options, because once we have missed that stage in their management, then it's going to come and bite us really bad. We really want to get the diagnosis right at the earliest stage. There is a concept of this grift, which is the getting the diagnosis right at the first stage. If it is a cancer, then we want to diagnose them, stage them, so that we can offer them the optimal therapy. And that may not be endoscopic option. We may want to send our patients direct for a surgery. And not all patients actually require drainage. And therefore, the role of MDT do come in. And we always stress on how important it is to get MDT colleagues on board. But we also know MDT is as good as information you provide them. I've been in several situations where cases have been discussed in other MDTs or in our own MDT when I wasn't part of the MDT. And if you're not there and if you're not advocate of your patients, you will not get the best result for your patient. So please be best advocate of your patients as possible. We do not want to make decisions that we want to then come back and regret. Important message is, we do not want to be heroes. In HPB world, what I have learned is things that I've done well, I've been hero. And then things that I've not done well, I've been zero. So there's nothing in between. Now, let me take you through a case. And I think this will hopefully highlight the point that I want to make. So this was a young girl who was referred to us with painless jaundice. And we know most of the time it is painful for us. She has a history of PSC diagnosed about 3 years ago, and then she also had an active inflammatory bowel disease, colitis, at that stage when she was presented. And you see the blood test there now. Obviously, we use slightly different. So bilirubin there is in micromole. So this is from sort of the 21st September was, I think it was a Thursday or a Friday, and 25th was the Monday. So this was her blood profile. She had this cholestatic jaundice. She also had raised inflammatory markers at that stage as well. So what did we do? So the MRCP that you see, you probably would be able to appreciate a stricture there. Now, later on Monday, this was her picture. So look what's happened to her bilirubin from there to there. And look what's happened to her stricture. So did I do an ERCP over the weekend? No, I didn't. So what happened? I think we learned yesterday in that quiz that patients with PSC can have a dominant stricture. So the advice or the recommendation that we have is we do not want to offer biliary decompression or intervene if it's a patient who has a PSC and they do not have a dominant stricture. Even if it is a dominant stricture, and no matter how competent you are, it is really important to at least discuss it with colleagues who are in the region or those who you regard as an expert. So in our policy, if I think somebody needs it, I always make sure that I discuss it with another of my colleagues before I proceed. So there are a lot of factors that we want to consider. Is it benign? Is it malignant? Is it hilar? Is it distal? Can I offer this patient hot Whipple? Can I send this patient straight for surgery and avoid them having a biliary decompression? We want to get cross-sectional imaging as much as the data we want to gather as much as before we offer them an intervention, an MDT. But, as I said earlier, MDTs, there's always this discussion. You always find challenges when you're trying to make other colleagues understand. In my practice, I know colleagues who are accomplished surgeons, who are accomplished interventional radiologists, and they do not understand the evolution in the world of the HPB endoscopy. So you have to have an open mind. You have to be ready for the challenge that you may face. Another case of a 41-year-old man, this time he presented with a painful jaundice. Now, please keep your eyes, obviously if you can see it on the screen there, it may not be a perfect cholangiogram, but please keep an eye out for that. Patient had an ultrasound scan which demonstrated gallstones. So patient had a biliary obstruction of some sort. However, the report wasn't entirely clear. Patient was offered ERCP. So this was the cholangiogram. And I guess if I had seen it, I would have said, oh, yeah, so it's an obvious stricture, looks malignant, no doubt about this. What happened afterwards? Patient had a metal stent placed. And what afterwards? They developed a post-ERCP pancreatitis. The CT scan that was done afterwards, you don't want to see that images. There was hardly anything for anyone to see. So we left the patient pancreatitis settle down for 4 weeks, and then we did an EUS examination. Now at this stage in EUS examination, let's hope if you can spot. So you see the stent squash, and what do you see? A meniscus sign. So there was a stone there. It's just compressing the stone. Where was the stone? Obviously, the orifice of the cystic duct. So actually, patient had a Mirizzi syndrome. So patient then went on to have a cholangioscopy. We managed to get rid of the stone, and therefore patient was able to then obviously recover. Fortunately, he did not had a malignancy and he didn't have any further complication from the pancreatitis. So is it malignant? Is it benign? If it's malignant, is it operable? If it is not operable, what should be our pathway? I mean, out of these, green, amber, red, what do we want to do? I guess in most cases, our preference is to do imaging modalities followed by EUS. So we want to diagnose a problem, a pathology as best as we can, and then consider biliary intervention. That is the case where we cannot offer them a surgery straight ahead. And then obviously, depending on what we can offer, chemo, palliation, or what sort. So this is a group which I think I can understand there can be a lot of debate around it, but this is a group obviously we do not want to do, especially if you are suspecting an underlying stricture. Now in this group, when we actually can do a CT or MRI scan and can want to proceed straight to the biliary decompression, the process that we follow is if they have a mass forming disease, yes, we could go straight for the ERCP, but if there's only a stricture without an associated mass, in those situations, I think it is best to have an EUS available as well. This is from the recent ESG guidance, hot off the press, published only few weeks ago. And I think you all know the different etiologies. Is it malignant? Is it inflammatory? Is it to do with a post-surgical complication? Has it got to do anything to do with the vascular anomalies? Or it could be other things like malignancy or AIDS related, as I mentioned. Important thing to bear in mind is it a mass-forming stricture? Or is it a stricture which is associated with the mass? Because then it can decide you what modality of intervention or biliary decompression you're going to offer this patient. You're going to see a lot of lymph nodes if you do an EUS. We see a lot of lymph nodes, especially in the perihilar region, even with the cholestatic disease. I've diagnosed a lot of PBC patients purely based on these hilar lymph nodes who've been referred essentially as a malignancy. Chronicity of the disease. Remember, a difficult disease will declare itself. So you need to be a bit patient. If it is a malignancy, it is going to declare itself. So patience is also a key. Then obviously we find ourselves stuck in a middle ground of these indeterminate stricture, which are definitely can be mind-boggling. So the guidance, I know it's a very busy slide, but what I want you to concentrate on the takeaway messages is, I think the ESG guidance is MRCP. If that is not available, then yes, we can consider doing a CAT scan. Now, in our practice, what we have seen is we want to offer them a combined option of doing an EUS followed by an ERCP. I know that may not be logistically possible, but what we have also observed is if there's an obstruction and we do an EUS and take a sample, this patient can then become cholangitis if we are not able to offer decompression in the same session. So it's important. We want to use F&B needle these days. There are other modalities if you're doing an ERCP, such as brush cytology. Fluoroscopic guided biopsies also become part of the guidance, but we've got to be careful. There has to be a word of caution. If you are not experienced, then it's probably best to get somebody else's on board before we do that. And I think if that doesn't work, then obviously we've got an option of doing a cholangioscopy. Now, there are further things that we can still offer, including this intraductal ultrasound, these cone focal laser, endomicroscopy, but those things are not widely available. And I think as far as the data is concerned, there is no concrete evidence that those things definitely work. Other things we can do, we can take more samples. I think there's a study looking at if you do it 30 times brushing, may yield better results, longer brush, thin preps. You can do those cytology adjuncts, but again, they are limited in terms of availability. Fish, things like those also have false positive rates in patients with the PSC. So there always has to be a middle ground that you have to aim for. If you're doing an EUS, we really want to, especially in those where you're suspecting an indeterminate stricture, you want to get it right first time. So you want your cytopathologist on site as well. So EUS actually has transformed the management of patients with biliary strictures. It allows tissue sampling, sensitive, more specific than cross-section imaging, helps us to do these F&B these days better than obviously the brushings only, most helpful in distal strictures. Now, although I've got this hilar stricture in cons, but we do offer patients with hilar strictures EUS, because I think there's enough data, and in our practice at least it does seem to work, and it is not as difficult as it appears in the literature. However, if the patient is a potential candidate for a transplant or a surgery, you really want to make sure you've run it past with your colleagues in the MDT. PSC is a black box of hepatology. We've seen so many patients where they've been offered interventions and then they've ended up having a transplant. So the commonest cause of transplant in PSC in our practice is recurrent infection post-intervention, mostly ERCP. How many of us are still doing barium enemas? Anyone? So why are we still doing ERCPs? You can have information, but it's limited. I showed you a case earlier where there was a stricture which seemed like a malignant stricture, but it wasn't. So I think if there's any doubt, we want to utilize the best available modality. It may not be available in your center, but it may be available somewhere close by, and therefore you may want to consider it. I appreciate the limitations, but I think wherever we can utilize it, we probably should consider it. Now, initially, obviously, the initial scopes, we didn't have a very good optical diagnosis, good visualization. There are lots of criteria that have come in. We've been using Monaco criteria for at least a few years, where we actually trying to look at the symmetry of the stricture. How is it presenting? Is it a nodule? Is it a polyp? Or the mucosa, because we can also have this papillary projection. And we've seen a lot of cases with these IBMN, which is intrabiliary mucinous neoplasm. Mucosal vessel ulceration, we felt that is what clinches the diagnosis. But not truly. I mean, also this criteria based on the evidence suggests it up to 70% of diagnosis. But if I'm honest to you, seeing is believing. But the only truth known to mankind is pathology. So you see a stricture and you think, oh yeah, it is bang door malignancy. But on the biopsy, that hasn't been the case. And I think that is, and not only anecdote, there's also evidence to support this. So yes, seeing is believing, but it's best if it's done under the microscope. Now, there are some other things. I've got a limited time left, but I think that's also important. When you start doing an ERCP, you want to, especially even when you're doing a cholangiogram, occlusion cholangiogram, post duct clearance of the stones, what you want to do is you want to divide it into two phases. You want to do an intrahepatic cholangiogram, and then you want to do an extrahepatic duct cholangiogram. Why it's important? Because it will show you a lot of time that you've got this altered anatomy, when there's the trifurcation, when the right posterior duct is joining the left duct, when there's obviously the right posterior duct is joining right into the hepatic duct. The concept of doing a unilateral or bilateral stents is outdated, and that's based on the altered anatomy, also based on the concept that what we want to do is, in order to achieve adequate palliation, we want at least 50% of the drainage. Something else that I've learned from colleagues in India, we don't want to inject a lot of cholangiograms, and I think based on what fluoroscopy we have available, it may not be very obvious, especially in the heat of the moment when you're actually trying to struggle and get the wire in the desired segments, and you end up injecting inadvertently a lot of contrast and you regret afterwards. So technique of doing an air cholangiogram is safe. There are a lot of concerns initially mentioned, but there's definitely a data suggesting that that can help. We want to dilate the stricture before we want to place the stents. As far as the stents are concerned, we want to drain at least more than 50%. That is determined once we've done an adequate cross-section imaging and determine which lobe is mostly involved, because after a while, the predominant lobe will get atrophied, and stenting that lobe is not actually going to make a massive difference. I guess where we are, we have to rely a lot on the plastic stents. We may have to go back and intervene a lot, but the survival benefit comparing metal and the plastic stents essentially remains much the same. With regards to the uncovered metal stents, where we don't want to, we want to use them, we want to avoid using the fully covered stents. What we prefer is, when we're using plastic stents, we want to preface stents. There's a stent from Cook called Johilin stent, which is actually a stent which is polyurethane, not a polyethylene. It's a flexible plastic, less risk of developing that biofilm, and less risk of obviously developing cholangitis. And also, if it migrates, it's very easy to withdraw. Because I think the other rigid stents can be at times very difficult to place endoscopically. With regards to the metal stent, if you want to remember one thing, remember there are two main types. One are the closed cell, and the other ones are these open cells. The advantage of the conformity, especially when you're trying to negotiate the tight strictures, then we can do either a side-by-side or stents through the stent mechanism. Two more case vignettes, again, really important. This was a patient who had a metal stent placed in, but the actual diagnosis was lymphoma. So what happened? That patient actually suffered. So if in doubt, go for plastics. Another important patient, another patient who actually had a cholangiocarcinoma. I think it was a presumed diagnosis, but that was probably the correct diagnosis. Had an uncovered stent placed, and then he kept coming back with recurrent cholangitis. So the message there is, our patients are dying from the stent-related infections, cholangitis. They're not dying from the cancer. Thanks to our oncology colleagues, thanks to all the advancements that we've had in the field of oncology. So it's really important to choose carefully. This is kind of a logarithm that we tend to follow if depending on the anatomy, depending on the access to the papilla, and then we decide what sort of modality. Are we going to go with the standard ERCP, or are we going to consider EUS guided modalities, which are several? And then I think we still have to consider PTC, because I guess that's what's widely available and that's what most centers follow. Our evidence from England is that there is a lot of morbidity and mortality associated with the PTC. So if we can avoid it and if we can offer EUS guided intervention safely, then we probably should consider them. And I think that's what probably is best for our patient. And the evidence supports that EUS biliary guided drainage is better compared to the PTC. Now, hopefully the last two slides, and I'm very grateful to Sandeep, who has contributed a lot to my development, and this is a paper written by him. And what they've sort of come in that if papilla is not accessible, you can consider percutaneous or EUS guided biliary drainage. But in terms of the low patient discomfort, no loss of the bile outside, and again, you don't actually have to traverse through the tumor, which is where I think the new concept is. And I think Professor Niaz earlier mentioned that once you've got a stent in situ, you can take your cholangioscope through that and can not only take biopsies, can offer treatments like radiofrequency ablation or whatever available. That's another colleague of ours who's doing an amazing job. And this is a recent sort of systemic review and meta-analysis where they've compared that once we have done an antegrade stent, which has been our preference. But what we then observed that after puncturing the left lobe, they tend to develop a bit of a bile leak and in some cases a bit of a biloma. And in those cases, if we go through the antegrade stenting and at the same time, if you could do an hepaticogastrostomy, that is the group of patients which have a better clinical success and less overall side effects. Lastly, there's a Professor Kongam, I believe, who has contributed to the development of several of our colleagues. So the concept there is we are actually stenting the right side through the sort of retrograde approach and also doing a hepatogastrostomy and utilizing both modalities for the benefit of our patient. So the new concept, or the concept that I want you to take away from today's conference, is that we do not want to go where the actual tumor is. If we can bypass it, so this is the acronym that I have come up with. This is a paper that we are actually writing up. But I think if we can bypass the tumor, the advantage is there's no tumor ingrowth into the stent. And therefore, the problem of patients coming back with a cholangitis can be easily avoidable. So, chairpersons, ladies and gentlemen, in conclusion, with multimodalities available, our diagnosis is improving, although indeterminate stricture does still remain a clinical challenge in some cases. We want to choose our stents wisely. So as I said, our preference is now becoming toward plastic polyurethane stents rather than metal stents, especially if there's any doubt in the diagnosis. Be your patient's advocate. Yes, do utilize MDTs, but you're not going to get it right all the way, all the time. So therefore, make sure you make the most of your colleagues. Thank you ever so much once again listening. And as I said, I'm truly grateful to all my colleagues. The font is basically computer generated, so it's not in my control. Thank you.
Thank you very much, Dr. Deem, for an excellent presentation. There'll not be any question answer session because of the shortage of the time. We are going to go straight for the PSG journal launch. Can I request Professor Shumail to moderate this session? The question answers for this session will be taken with the next session just before the lunch. So all the speaks will be available, and we can combine the question answer session for the two sessions.